today I'll be giving a lecture to you about how doctors get paid and just an introduction to the payment models. And so a lot of you guys already kind of know me. I do the personal finance lectures at U of T, and I'm also on the financial aid committee, doing like reviewing grant and scholarship applications, things like that. And I actually got started doing these personal finance lectures when I gave webinars to the diversity mentorship students at U of T. So a lot of these students were coming from lower income backgrounds, and they didn't really know too much about affording medical school. And so those were my early days of getting started. Some of you might know me from Breaking Bad Debt, which is my blog on Instagram. And I do addictions medicine as part of my day job. But most importantly, I actually went to Queen's for undergrad, and it's great to be back at my alma mater. So this was the last picture I've ever taken of myself at Queen's at Stauffer Library. And so today we'll be talking about kind of like a broader overview in terms of different practice styles, academic versus community, remuneration models. There's so many different kinds, FITs, FOs, FIGs, like you've heard it, all of those random terms. So I'll talk about what is it like to be working in each and how much you'd be getting paid in each of them. And lastly, I'm going to talk about the MD side hustle. I know that a lot of people, not all doctors do only clinical medicine. And so I'm going to talk a little bit about what other doctors do as well. And so even though part of my master's was in health policy, I find that I'm not going to be talking too much about the policy aspects of how doctors get paid, like the private versus public payer models, how like healthcare is funded provincially, things like that. Because I think, at least at U of T, we get that in lectures in school. So what I'll try to focus my lecture on more is the guidance counseling aspect of it. So moving on, I don't have any conflicts of interest to disclose. I was going to be paid a speaker's honorarium, but I've decided to donate that for prizes for you guys. So what did you guys, like for the organizers, what did you guys end up buying actually for the prizes?
I think we're giving away one book.
Okay, which book?
Wealthing Like Rabbits.
Wealthing Like Rabbits, cool, that's a good one. So so I'll be asking like a random question during the talk. And so I guess some person will receive the book. Okay. And so you kind of know about me already, but I want to kind of get to know about you guys. And so just to kind of get you guys involved in participating, I have developed a poll everywhere poll. So if you wanted to join, okay. So just to get to know you guys, I am a first year med student, second year med student, third year med student, gap year MD PhD. Okay, so it looks like there's a lot of first and second years. Okay. Next question. So preceptors and staff physicians have talked to me about how they are paid when I'm on shadowing or on rotations. Okay, so it looks like for the majority of you, you haven't really had that kind of talk about how doctors bill and things like that. Okay. Next slide. I am comfortable asking my preceptor or staff physicians about billings and how they get paid. Okay, so a lot of you guys aren't comfortable. To be honest, I wasn't comfortable myself either. There's a lot of stigma with asking these kind of questions, and you never know if a preceptor will not be comfortable answering. Okay. And lastly, I am currently interested in family medicine, a specialty, oh, lots of surgery, and then a lot of unsure as well. So I'll tell you that my background is mostly in family medicine. And so you'll find that part of the slide will be kind of on the family medicine billing models. but I'll also be touching on surgical and specialty billing models as well. Great. So before we begin, we kind of want to talk about the two biggest settings that doctors tend to work in, academic and community. And by academic, I'm going to kind of clump that as hospital as well. Not all academic hospitals, there are some community hospitals as well. But by academic, I refer to working in a hospital setting. And so the main difference is that when it comes to academic, usually overhead is very little or none at all. There often isn't billing software that's built in the EMR or the electronic medical record system. And so a lot of doctors have to kind of find their own way to bill. There is teaching and research responsibilities. Some of it might be paid, some of it might be unpaid. There can be complexity of cases. And lastly, with regards to allied health support, there's quite a lot of allied health support, either by way of nurse practitioners, med students, residents, and so on. And in the community, there is a higher level of overhead. And so from the CMA Physician Workforce Survey, you'll find that generally overhead is approximately between 20 to 40%. And overhead is basically something that just covers your staff, your clinic rent, and things like that, or your clinic equipment. There's usually a billing manager in a community work setting. So this is someone who might do the billings for your group for you. And your EMR system will likely have an ability to submit your billings, unlike your hospital EMRs. And it's quite fast paced, to be honest. And there isn't that allied health support too. So the reason why I wanted to touch into those types of work setting is because your work setting is what determines your payment model, and it also determines your overhead. And overhead is important to consider because when you have a high income, overhead and taxes are going to be your two biggest expenses cutting into your income. And so in this particular diagram, it shows that most GPs and family doctors, they work in a community setting, whereas most specialists tend to work in a hospital or academic type setting. And so this type of setting is what determines how these GPs or specialists get paid. And so let's kind of talk more deeper into the types of remuneration. So the most popular one that you may have heard of is the fee-for-service model. And you'll see this a lot in like walk-in clinics, focused practice settings, community specialist settings, as well as a lot of academic and hospital settings too. And so in fee-for-service, it's the simplest billing model. You basically bill for each service provided. And most doctors, as you can see, family practice and specialists are billed through the fee-for-service or the enhanced fee-for-service models. More on that on the next slide. So when it comes to enhanced fee-for-service, this is when you get these bonuses for seeing more complex patients, or if you're in a rural setting, or working in the weekends and evenings. And you may have heard of the term FIG, which is a family health group. And this is an example of an enhanced fee-for-service where you can get these preventative care premiums for doing things like making sure your vaccinations are done. There's also the comprehensive care model, which you may have heard as well. And in this type of model, this is not that used anymore. It's used by less than 5%. So it's basically like a FIG, but just with one doctor. But most commonly, you'll see in the academic centers and in emerge settings, you have an alternative payment model. So for example, one of my emerge colleagues might be paid for working in an emerge shift. They might get a $1,200 base payment, like a stipend. And when they bill, they only get 10% of each of their billing codes. And this is known as shadow billing, which means that you're not actually getting the full amount of each billing code you submit, but kind of a shadow of it, a smaller percentage of it. And the whole reason why you're billing anyways is to kind of keep track of the types of patients that you're seeing so that the hospital knows that, oh, you saw this many patients that day with these kind of diagnoses. Okay, so why would I want to work in a fee-for-service model? For example, most specialists might work in this model. The good thing is that it's quite simple and it's flexible. So you don't have any after hours requirements, just like a shift work. You don't really have those after hours requirements to provide care on the evenings or weekends. You don't have to do it. And you don't have rostered patients, which are patients that are tied to you. So an example of that is something that I'm doing, which is telemedicine. The downsides of working in a fee-for-service model is that because there's not a lot of bonuses, the pay may not necessarily be the highest because the pay is really dependent on high volumes. So if you don't work, for instance, then you might not get paid. So if you're taking a vacation, you're not going to get paid for that vacation. And like I said, you might see this a lot in high volume settings, like in walk-in clinics, and if you do paying clinics where there's a lot of quick procedures. And this can be stressful, especially in trying to maintain that volume. So let's say if you saw 12 patients per day as consults, you multiply that individual billing code that you see for that patient times however many patients you would see that day. And the reason why I post this as pre-tax, pre-overhead is because overhead tends to fluctuate. Like I showed you earlier, it can fluctuate for between 20 to 40%. 40% being quite high and taking away quite a large chunk of your payment. And tax, this kind of varies based on your overall income. So there's also the blended capitation model, and you see this type of payment model as in primary care, especially in high needs areas, as well as in some academic family med clinics if you do end up doing family medicine as your residency. And so capitation, what it is basically it's like a fixed payment for each patient that is rostered or enrolled in your practice. So for example, and it's also dependent on age and on sex. So for example, in your clinic room, you might have a 24-year-old male. You get a baseline of around average $90 per year for that patient. And if you have a female, approximately $200 just without actually doing anything for them. But I'll tell you more about that later in another slide. This is just something that's kind of like a subscription fee that is paid for each patient to subscribe into your health service. On average, you would get approximately this much per patient per year. And so capitation is a sum of the base rate, which I talked about earlier, the comprehensive care fee, which is basically for doing preventative care and for actually providing good care to patients, and an access bonus, which is meant for patients to access your care. So if you're getting paid a base rate, but you're never there, you're not really accessible to your patients, they're going to go out to see walk-in clinics, they're going to go out to see telemedicine clinics and so on. And so this will cut into your access bonus. And so this kind of makes it a bit easier it looks like a lot of numbers, but it just, for your reference, in terms of, females, they tend to pay a bit more than males just because of the more complexity of screening and things like that. And as you get older, you get more complex. And so that's why for the base rate, or sorry, well, I guess for the base rate, there's a higher base rate. And overall, there's like a higher capitation that you get paid for these older patients too. Now, if you're a specialist, this might not apply to you because you just basically bill the fee-for-service code or the consult code. This tends to be very popular in family medicine practices. And so you might hear the term shadow billing, especially for those who have that alternative payment model. If you're going for Emerge, for example, some family doctors working in the family health organizations or FOs might be billing through shadow billing. And so like I explained before, the schedule of benefits, if you were to Google it, it basically tells you all of the billing codes for every specialty out there. And it also tells you how much you get paid per consult you see. And so whenever you see a patient that is capitated and rostered under you, you can only keep 15% of what you bill on top of that capitation amount. The reason why is because these patients are already, they're already subscribing to your care. And that capitation is kind of like a subscription fee for them to see you. And so, this is only for anything additional that you see them whenever they visit you. And so that's what I was talking about with the base rate. The base rate is basically for these expected services. And I also mentioned a key term, which you might hear around, which is called in-basket services. And these are basically services that are provided that you are expected to give to the patient, especially if they're a family medicine patient. If they're out-of-basket services, which might be example things like if you do family OB, if you do ER on the side, or if you provide palliative care on the side, you keep 100% of those billings instead of only 15% of the billings. And finally, you get these bonuses for after-hours care as well. And so some practice models that use blended capitation, you might see family health networks, you might hear about family health organizations. And the main difference is that, this tend to be more in rural practices. So the Queen's Family Medicine Health Team, Family Medicine Network, this is an example of a FIN. And a family health organization, we see this more in downtown Toronto, for example, or in the academic health teams in residency. And lastly, so the difference between these two is that one is in how many in-basket and out-of-basket codes to bill. So for instance, all family doctors will use these common billing codes, particularly this document. I've included the link down below. And how you will know if something is considered in-basket versus out-of-basket is based on these things here. And so you'll see that there are more FHN codes than there are faux codes, for example, that might be considered out of basket. So these are things that you can get 100% paid for. So why would I want to work in a capitation model? So, if it's done properly, it rewards comprehensive care. So, if you get paid for seeing patients in full comprehensive family medicine, and you still can get paid if you take time off work. The payment is higher than fee-for-service for the same amount of volume. And if you are deciding to settle down in a location, you're committed to doing full family medicine, this might be a good model to work in. So the downside of it is, if you're not committed to a particular location, you're not committed to certain hours or to having patients tied to you as a roster, you might not want to work in this model. If you, for example, run a walk-in clinic one day and you see patients for the rest of the day within your family health organization, there's like a cap of how much you can make just doing, fee-for-service work as part of the walk-in clinic for your non-rostered patients. The billings can be more complex, and right now you'll see that with high demand of walk-in clinics, telemedicine usage, that will cut into your access bonus as well. And finally, there's not a lot of FHO spots out there either. So perhaps if you want to work in this model, it might be hard to get into this type of payment model. So as you can see, the pay is a little bit higher than just, general fee-for-service. And so this was a slide that compares each of the three types of payment models I talked about earlier. And this was presented to us at U of T's practice management today. And so you'll notice that this tends to be the average roster size for people who work in a family health organization. And even though you might see like this is such a high number, it's quite rare to see this. And you'd be probably working like surgeon's hours if you're taking care of 2,500 patients. The other thing to keep in mind is, you have to be available for this many patients in your roster. And at the end of the day, you have to think about, are you actually providing good quality care if you're rostering so many people and not a lot of people can get access to you? So just be very careful about, some of these you'll see that they pay quite a lot more, but the hours are also much more too, compared to the family health group and the fee-for-service type of payment model within family medicine. And so you might have also heard the term family health teams. And so, for example, I currently work in a family health team, but I actually get paid through the family health group model. And you might have also heard the term academic family health team when you guys are entering clerkship and when you guys are, perhaps some of you might go into family medicine. And family health team or FITs are basically just referring to the government funding to fund allied health and the clerical staff. And this actually helps reduce that overhead that you have to pay because you get this external government funding. Doctors are not paid through the FIT model. And so the other kind of model that you might see are salaries. And so you might see this type of payment model, especially if you're working in an inner city type setting, rural groups, as well as some academic centers like Sick Kids Hospital. The pediatricians or the doctors working there are paid through a salary model. And so community health centers is one of the most popular form of salaried model. And so if you have an interest in seeing patients who might be lower income, refugee health, LGBTQ, or patients who have complex social situations, working in a community health center is a good setting for that. The reason why salary model is good for these kind of settings is often, due to certain social determinants of health, like unable to access transportation, there's high rates of no-shows. And so if you're going to be paid by fee for service and someone doesn't show up, then you don't get paid, but you're just sitting around not seeing anybody. So that's why having a salary allows you to not be dependent on how many patients you're getting seen. It's non-dependent on volume either. And the good thing about this is that there's a lot of support through social worker and dietitian. And so what I like about this model is that it actually provides quite holistic care, because patients will access these centers for not just care for medical care, but they also will access for food, laundry services and things like that. And so why would I want to work in this type of model? Well, the main thing is that you don't have to rush patient care. It's not volume dependent. Um, you get these benefits like health and dental, pension, and vacation pay, all of which you don't necessarily get in any of the other payment models I talked about earlier. So, if you're working in a fee-for-service model as a specialist, you might not get access to health and dental insurance. So you might have to pay that out of pocket, or you have to buy your own. You might not have a pension either. And lastly, some places don't offer vacation pay either. And finally, some salaried models do pay for administrative work too. So checking labs and things like that. The downsides of being in a salary model is that you're no longer self-employed and you're an employee. And whenever you're an employee, you're not your own boss. There's usually, a board of directors. There's usually a CEO of that particular center. And so you might not have as much control into the running of the clinic. Income does tend to be a bit lower, and the cases can be much more complex. And so to kind of understand generally what the pay is like in a salary model, I actually recommend that you check out the Sunshine List. Because it's salaried and because it's public payer, the Sunshine List is a good way of seeing what a physician who's working in the salary model might earn on average, as well as the raise and so on. And also for those of you who are interested in working in healthcare administration, Sunshine List is another good resource to use too. And so the last component of this talk is about the side hustles. So what else do doctors do? And some doctors, they don't always practice only clinical medicine. And by clinical medicine, I mean direct facing patients, seeing patients like directly. And the reason why some people might, have some side hustles is because after asking a lot of like older staff, they said that burnout is extremely high. And, sometimes doing that side hustle work outside of medicine can add variety to your week. And so this particular diagram is actually American. It comes from the Medscape National Physicians Burnout Report. And so they have like a lot of different metrics, and I actually suggest that you check it out, because not only do they look at metrics on burnout for patients, they also look at how many patients from which specialties have the highest divorce rates. What are the highest areas of like what are the salaries like and things like that. So it has many different metrics that I would suggest if you're seeking to get more information about your particular specialty. And so, there are a lot of other jobs doctors do as well. And it's really interesting because I see that whenever people enter medical school, or when they're applying for medical school as a file reviewer, I see that a lot of med students have a ton of different interests. But then sometimes those interests fall away when they're a medical student, when they're gunning for a particular specialty. And so medicine becomes all consuming. And so it's always good to have some sort of hobbies that you're interested in, things that you like to do. Sometimes they can become sources of payment. Sometimes they're not, but just for prevention of burnout. And so just in terms of some of the jobs that other doctors do, some of them might do like medical legal consultations. So for instance, working for the CMPA, they might be independent medical examiners. There are some people who are interested in medical technology, so like physician innovators, consults for startups and industry. Some people might open med spas, do cosmetic practices. For myself, I do guest speaking. Some people might be involved in education as like an examiner for licensing exams and things like that. And we see this more and more now. I'm personally don't do this, but I do know there are some people who are physicians on Instagram, and they do have like ads, sponsored products and things like that, where they might derive a source of income from too. And there are also some people who are clinician administrators, policymakers, and things like that. And really, the sky's the limit. You guys, since as a med student, have certain interests. You might have stores, like things like that. I'll always encourage you to try and do something out of medicine on the side as well, just so that you can have some variety to your practice too. And so even your own dean, Jean Philpott, she's done politics on the side. Doctors Ray Musica and Greg Zeschuk is the founders of BioWare, which is actually a game development, the makers of some okay, like good games and some like okay games. You might also see like doctors like Dr. Ken Jeong, who's a comedian as well. So there's so much opportunities, so many different options for you to choose from too. And so I'm just going to end with some closing thoughts and just some resources as well. And so why are doctors paid the amount they do? As a doctor, we delay quite a lot of years of income due to school and due to residency. And we don't actually earn like a staff salary until our late 20s or 30s. Not to mention there's quite a lot of growing debt, and we do have higher student debt than the average. For those of you who've seen my other lectures, I have a slide where it kind of shows a graph of all of the student debt levels. And on average, medical students can expect to graduate with about 100,000 in debt. And so these are just some of the upstream factors that might be driving why some doctors might go towards higher paying specialties, or they might go towards trying to earn a higher salary to pay off these higher debts as well. Not to mention, in medicine, income is proportional to our work hours. So the more you work, the more you earn. Just like that diagram I showed, or the chart I showed you earlier, of doctors with high patient rosters. Those people might be working a lot of hours. They're working probably like surgeon hours to really provide care for all those patients. They might be the only doctor in a rural setting, for example, and so they might be working a lot. And not to mention, there's also a lot of unpaid work that we do as well. And so things like reviewing paperwork, labs, teaching and supervision can sometimes be unpaid, and charting, doing dictations, doing billings, those are all unpaid work in our jobs as well. And lastly, with the exception of being in a salaried model, a lot of us do have to use our incomes to self-fund health and dental. We self-fund our own overhead, so the running of our practice, self-funding our pensions, as well as our maternity leaves too. And so having that higher income, allows a lot of doctors to be able to pay for all of these services for themselves as well. And with the doctor's payment model, they're quite complex, and I wouldn't say that they're perfect. And you've seen that there are articles out there about the gender pay gap in medicine too. And there's a lot of news articles about doctors' incomes. It's quite a point of contention, quite a lot of debate around that as well. And so I'm going to end with this slide. So when I was doing my master's, I did courses on health policy. And this was from the Canadian Institute of Health Information. I remember seeing this diagram in one of my slides from my policy course. And doctors' income is the fastest growing area of healthcare spending. And even though it's growing really fast, it's a very complex situation when it comes to a policy standpoint. It's not a simple answer as we need to cut down on doctors' income, because we often have to look more systemically and look more upstream. What could be driving that doctors' growth in doctors' income spending when it comes to healthcare spending overall? And so, could it be that we're graduating more doctors? Could it be that doctors are billing more? It's hard to say, but perhaps it could also be as a reflection of the growing costs of tuition the growing cost of residency and CARMs, applying for CARMs, or even, the growing costs of the licensing exams, $3,000 to $5,000 in licensing exams and things like that. And so even though when we see that doctor's income is quite high, the expenses are quite high as well. And there's an enormous financial investment to be made to becoming a doctor. And so I'm just going to provide some resources for you as well. It's always important that when you guys graduate from residency to locum and to find which practice fits you, which payment model fits you as well. This is just a resource for the family medicine locums, but you can also locum as a specialist as well to get to know your practices. I did a video on YouTube about transitioning from resident to staff doctors. And so this can be a bit of a more detailed information on what it's like to become a new staff. There's also other information provided by Jewel on physician remuneration as well, and transition to practice slides made by Healthforce Ontario. And so I noticed that I'm going to leave some extra time. I think an extra 15 minutes is left for questions. So I'm going to try to address all of the questions that were piling up.